Hello, I'm Dr. John Kruse, and hopefully the internet will keep working well at my end today. So for today's question and answer hour, I will review the two videos that were released this week. Again, this is a time to ask questions about those specific videos, about ADHD in general, about mental health even more broadly. As a reminder, the comments here are not specific recommendations for anyone's mental health plan, but hopefully the information can be used both for your education and enjoyment, and maybe even taking it back to your treatment team if there is such a thing for you. And a reminder, if I do have a subreddit channel, so if conversations, writing questions, or getting into discussions with fellow listeners, that may be a good modality for some of you. So the two videos, and I'm sorry, there was just a weird glitch on the screen. Two videos that were released in the past week. One was on Centanafadine and ADHD, and the other was on marijuana and ADHD. So Centanafadine, as of this week, which is June of 2025, has not been approved by the FDA or any other regulatory agency I'm aware of, but there are, and it's in the works for being approved for ADHD. They've done their phase 3 testing. So this is a drug that is a triple reuptake inhibitor. It's norepinephrine, dopamine, and serotonin. And in the studies, it looks like it helps with ADHD symptoms roughly about as well as other non-stimulants do. And whether there are increased benefits or increased risks from being a triple reuptake inhibitor rather than just a single reuptake inhibitor like norepinephrine and Strattera, or norepinephrine and dopamine like bupropion and Wellbutrin. We will see in real life what it is like. I think pundits think it's highly likely that this will be approved at some time. The other topic was marijuana and ADHD, and this is one of the few topics where when I actually looked at the data, and the data collection is fairly small, it's one of the things that I've changed my mind on clinically. So clinically, before I looked into it, my clinical experience is that people who are regularly taking marijuana at a substantial daily dose, I've seen what the research suggests is that there's lower motivation, more disorganization of thought, low energy, motivation, organization. There's some other variables. Impaired memory are things I have heard people report to me, although some felt to help with their mood or other things. And although, again, there's data to suggest heavy daily use is associated with those issues, which you would think is a horrible match for ADHD, there is at least some subset of people, and we do not have markers to identify who is in that subset. And there are a handful of studies indicating that marijuana can be helpful with focus, attention, concentration in some people with ADHD. So I'll leave that at that. I see, hi Dennis and others, hi James Alexander, I have some questions, but before I jump into that, there's a question that Max forwarded to me from the subreddit, and I don't have good answers to most of it, but it was a lengthy question by user designer study, and it was about left brain, right brain issues. So I do have a left brain, right brain talk here on the video. So there are multiple parts to the question. So one is, are there other people writing or talking about left brain, right brain, and ADHD other than, Ian McGilchrist has studied, wrote prolifically on this. For mental health conditions specifically, his focus has been much more on schizophrenia, depression, anxiety. So I don't know active research going on with left brain, right brain issues in ADHD. It doesn't mean it's not there. I'm just not familiar with it if it is. In terms of other researchers or books, and some of this is bleeding more into sort of older research and more, I'd say, on split brain research. Certainly Michael Gazzaniga has written books about this, and explain things articulately. Some of that's probably a little dated, but useful information. One of the other questions is it possible that there's true multitasking going on, given that the left brain and right brain seem to be functioning with different types of attentional and consciousness processes? And again, except in split brain subjects where the corpus callosum and or other commissures connecting the two hemispheres have been cut, I'd say it's been really hard to assess or do good studies to figure out what's going on, or whether there's always only one entity in our brain that's fully in charge and we're switching back and forth between the two, or whether how much simultaneity there might be between a separate left brain process and the right brain. That's where I would say things are. So another question is, what can I do to increase right brain functioning? And my best resource there is there's a book that came out many years ago by Betty Edward. It's been updated recently, called Drawing on the Right Side of the Brain. And she goes through a bunch of exercises. Originally, the book was relying on some neuroscience to help people be a better drawer, illustrator, see the world differently. And I think it's actually her son now does workshops where the emphasis is more sort of the other direction. It's learning these techniques to engage more fully, use that holistic, less detail specific modality of thinking. And then there was a final question about, are there any cultures that are primarily right brain cultures? And it seems that part of it, and the questioner pointed out that because language is the language of the left brain, and so much of modern civilization is built on or relies so heavily on it, I think even if there were, so that this person surmised that maybe it's, as long as we've had language, all culture has been left brain oriented. I think there's, and McGilchrist goes into this, certainly some Eastern, at least from our perspective, we call it Eastern on a globe. There's really no East-West entity. It's a direction, not a location. But many Asian, Eastern, and Eastern, not just cultures, but religions as well, seem to do a more thorough job of focusing on the holistic and capturing the essence of something rather than getting mired in the details. So I don't know if I've answered that well, but that's my shot at attempting that. I'd say also, in my mind, and again, there is good research that Ian McGilchrist did. There's good split brain research going back to Michael Gazzaniga, and there's an Iowa researcher, Damas. Yeah, I'm butchering his name, I'm forgetting half of it. I do think there's some real kernel that some of it's really physically left brain and right brain, but I also think that many of our models are more models or metaphors or ideas, that there's a different attentional process system, again, a more holistic and a more detail focused, and how much of that in a daily functional life really depends on, clearly there are capacities for detailed thinking, for holistic thinking, even for language in both hemispheres. So it's not a rigid, one thing is here, one thing is there, and these are competing entities in all situations. So Dennis asked, do psychiatrists still perform psychosurgery? So the answer, so the first psychiatrist, and maybe at the top of mind, the only psychiatrist getting a Nobel Prize has been for essentially psychosurgery and lobotomy, not something we favor in this day and age. I'd say, so there's different levels to this question. One is, are psychiatrists still performing any psychosurgery? And I'd say, I am not aware of any instance where they are performing. Now we have whole fields of neurosurgery, so it would be surgeons actually doing the psychosurgery. But yes, psychosurgery is actually quite active and certainly rebounding, but rather than just lesioning or destroying part of the brain or cutting pathways to disconnect so much. Now it's much more about deep brain stimulation. So there's, for OCD, that's not been able to respond to any medications or psychotherapies. There's sort of a well-established set of procedures in psychosurgery for putting in electrodes that are either activating or deactivating certain parts of the brain. That's being looked at for many other areas. There's other interventions which may not be surgery, but are trying to actively intervene with brain activity, more using electricity or magnetism or even light, whether that's, you consider that psychosurgery. The other area where there's psychosurgery going on, and again, this is more focused so far on physical systems like people who have paralysis and people who have vision problems, but the interface between, and Elon Musk is, one of his projects is heavily involved here, is involved in making essentially bionic brains. And some of those certainly are going to be addressing problems we classify now, right now, as psychological rather than neurological. I mean, there's sort of a flippant quip that once we learn what something caused, the causality or the pathways, then it becomes, instead of a psychological problem, it becomes a problem of neurology. But hopefully I've addressed that one. So James Alexander asks, for patients who want to try modafinil, how long would you typically have them try each dose? 100 milligrams, and he's suggesting 100, 200, 300, 400, et cetera, to see if it works past the stimulant honeymoon period before moving on to the next one. So I guess one is how, if someone's not having a response to a given dose, so there's two sort of different questions embedded there. The first one is just, how long would you wait, presumably if they're not having much of a reaction, before going up? And my answer there is, given that all the both basic science research and the clinical experience I'm aware of indicates if modafinil is going to help with your ADHD symptoms, it's going to help. It's a direct, immediate effect, and within minutes to hours. So there is not much point spending more than 2 or 3 days at a given dose if you're having minimal to no results or inadequate results. So the second question is the potential for, is there a stimulant honeymoon? So might someone get a bigger effect in the first few days or weeks than they do after they're 3-4 weeks or longer into it? I have seen that be much more of an issue with stimulants themselves. And I've seen that be less of an issue with non-stimulants like bupropion or atomoxetine or modafinil. So I'm not saying it can't happen. The other thing, and some of this is in my video on modafinil, the other thing, most of the early research when, I'm forgetting the name of the company, has Cephal. Anyway, the early research on modafinil suggested orexin receptors were the major pathway it was interfering with in the brain. And more recently, the focus has been it's just a dopamine promoting agent. I think maybe the reality is somewhere in between the two. But even though it's billed for decades as a non-stimulant stimulant, I'd say about 10 to 15% of people, and it's not larger than that in my experience, most people don't feel too revved up or don't feel too agitated. They just feel alert and or maybe better able to concentrate if it works for them that way. Anyway, about 10 to 15% of people do feel a more classic stimulant revved up, even jittery approach, and almost always, and interestingly, I've had several patients, some who had never experimented with drugs, all described as feeling like they were on bad crack, cocaine. Again, some who had never even tried cocaine, so it's not clear why that would come up as an analogy for comparison. In my experience, if they stuck with it for a few days, that overstimulated, revved up sensation went away and they got benefits from modafinil. So that's what I'll say there. So Dennis is saying Dr. Robert Melillo, a functional neurologist, has done extensive research on left brain, right brain imbalances and mental disorders. So thanks, Dennis, for bringing that reference. And I'm not, again, clear what he has shown or done regarding ADHD itself, but I will be looking him up to see. Hello, Beth LM again. Are there other triple reuptake inhibitors already? Has this been deliberately designed, or it was an accident and just been lumped over to treating ADHD? And asking me if I'm okay if I have a cold. So I've been traveling for 4 weeks. Last Tuesday was right after 2 days of severe sleep deprivation and the airport mishaps. Planes weren't the problem, but just delays getting into Newark at 2. And there were 4-hour delays messing with circadian rhythms. So I only just got back to Hawaii last night. I think it's allergies. I don't think I have a cold, but I have been coughing already today and might do so again. So I get back to, so when we talk about whether something is a pure SS, so many people say, oh, the advent of modern treatment of depression was the SSRIs, like Paxil, Prozac, Zoloft, Luvox, Celexa, Lexapro. But actually, we had reuptake inhibitors that were the tricyclic medications. Many of them were, I'm blanking now, begins with a vowel. There's one that's primarily serotonergic that's used extensively in OCD. So when we're talking about reuptake inhibitors and whether they're clean or dirty or specific, all of it is sort of relative. If you push drug levels high enough, even drugs that seem to be relatively clean for one receptor may start having some mild inhibition at others. And how much of that's clinically relevant in individuals varies a lot. So something like Paxil, which has been promoted and used as a serotonin reuptake inhibitor, has somewhat stronger norepinephrine reuptake inhibition than those other clean drugs. So some of the tricyclics do moderately strongly affect serotonin, norepinephrine, and dopamine. The problem with the tricyclic antidepressants is that almost all of them were also strong antihistamines, had strong effects on the acetylcholine system, have effects on sodium ion channels. So they are messy, messy drugs working on lots of systems and causing lots of side effects, including dangerous ones. So again, I have video information on that. I'm not sure which video. So whether this is truly Centanafadine, the first triple reuptake inhibitor, it's sort of the first cleanly affecting the big three of serotonin, norepinephrine, and dopamine, and it is strongest on norepinephrine, at least in the lab. So I do not know. When we say deliberately designed, I don't think they said, can we find a drug that does this? I think they have lots of drugs in their pipeline development system and looked at this one because in its assays, oh, this looks interesting, let's try it. So that's all I know right now about the development or selection of it. I'll just call you CB because I'll butcher your name otherwise, asks, why could Centanafadine be better than Qelbree? More generally, it seems that Qelbree already combines well with existing ADHD meds. I mean, one thing is we so often focus so much on what the drugs do initially, whether this is an MAO inhibitor, whether this is a serotonin receptor uptake agent, whether it's affecting serotonin 1A receptors. And For many of our drugs, those are just the immediate effects, and it's how they may well have more profound or significant or clinically important effects downstream from the very immediate, what you're getting in the first hour or two. And so my point there is, for most people, Cymbalta, a serotonin and norepinephrine reuptake inhibitor, is more tolerable than atomoxetine, which is, oversimplifying, but strongly a norepinephrine reuptake inhibitor. So sometimes by affecting multiple agents rather than causing more side effects, because part of it's these systems modify and modulate each other, it may be a more balanced, either more potent in the long run effect at changing the system, or more effective at preventing excessive side effects from one angle of what a single agent could do. That's pretty generic and hand-waving, but that's how I try to explain it. So Beth LM asks, do I have clinical experience of or awareness of studies looking into ADHD medication adverse side effects or medication intolerance due not to the active ingredient, but to the excipients in the tablet? So the excipients are liquid. So these are all the quote unquote inactive ingredients. I mean, one of the things that RFK Jr. is working on in the US is banning a lot of artificial dyes, and out of fear that, some of them have been found to have carcinogenic which is cancer inducing effects, or teratogenic, which is effects on the development of a fetus effects. How common or how prominent these problems are is unknown. One of the things that sort of amazes me is, so far, and maybe this will change in this administration, generic versions of the drug, all that's focused on is the active ingredient itself. So the pill doesn't need to be the same size, the same color, the same flavor, the same shape, which I think leads to lots of problems, particularly with, this is stereotyping, but elderly people who are on multiple drugs. Each month their blood pressure medicine may be a different color, shape, and yet they've learned, oh, the pink one is for my blood pressure, this is for my cholesterol. But in terms of the inactive ingredients, there are something, and I have a video, or at least a Medium article, where I wrote a little bit about this. There are thousands and thousands of substances, most of which the FDA says are okay to use, because so far we haven't found problems or damages to them. But the vast majority of them have not been studied extensively. And even though there's thousands of ingredients allowed, there's a cluster of, and I think it's in the range of 40 or 50 or so, that are extremely widely used repeatedly. Those are the ones clearly we have more information. So getting back to the question, I'm not aware of any studies suggesting that component A, B, or C is particularly bad for people with ADHD or particularly helpful, maybe having adjunct active effect, with the exception, again, there is some work, and I'm forgetting, is it Feingold? There are some kids with ADHD who do seem to be sensitive to certain dyes. When they've tested broader groups of kids in general, and even kids with ADHD, this is clearly not a majority of kids with ADHD, but it does seem to be that there's some subset of individuals. The other factor here that I've seen clinically is, I'd say, placebo or psychosomatic effects. So I've seen people who are convinced that lactose, which is one of the most common effects, most people who are lactose insensitive can actually tolerate a small amount of lactose. And it's when you get lactose that's more than the amount found in about a cup of milk, that most people with lactose intolerances develop serious effects. But these are individuals who are feeling that just microgram amounts of lactose were having profound effects on them. And that with one of them, I actually did sort of not double blind, because I knew it was what they were getting each time. different products from different manufacturers, some with no lactose, some with lactose in it. And even though they were convinced and done research to find with all sorts of drugs that they were responding to the lactose, when we did a test where they didn't know which product they were taking, they didn't have symptoms associated with the lactose and an absence of symptoms with the non-lactose. It was random. So I think there are real effects in some people. I think there are also psychological worries or fears that compound. And again, people vary in their sensitivities. So that's where I leave that. Hello, Max. Good morning, or evening for you. Max asks, is there utility in categorizing addiction disorders for each individual one rather than just having a standalone condition which can entail any possible kind of activities or substances? I mean, some of this is philosophical in terms of whether you're a lumper or a splitter and forming big categories or little ones. I'd say, to my mind, there is a certain similarity of differences we've seen in dopamine activation circuitry in terms of, the criteria, the symptoms we use in terms of, has someone tried quitting? Do they have withdrawal symptoms? Do they have tolerance? I think there's certainly a core, that there are real similarities between activity addictions, whether it's sexual addiction, gaming addictions, or substance abuse addictions. But it's also pretty clear, just in terms of the field of substances, there are some people who seem susceptible to alcohol, tobacco, cocaine, who abuse multi-substances, and there are some who other substances are certainly their jam and nothing else is really exciting or attractive, or they're not likely to abuse others. So I think there's some value in identifying which substances or activities are part of the current addiction. Not that means someone's always fixed or locked into that. And that's separate from the whole bigger picture of our whole psychiatric mental health diagnostic criteria systems need refinement. So James Alexander asks, do I believe that there are any, and I'm glad, thank you for throwing in believe. So again, I try to look at science. I think I have partly the PhD training and partly because my brain worked that way is why I got training in PhD. So I try to be more rigorous, but I am also aware that in my clinical experience, I will only see a fairly small number of people, and my beliefs, my impressions are going to be strongly shaped by what I see. So I may need to get the dog up or out in a minute, but so theoretically, the armodafinil, the right-handed, so in modafinil, you have 50-50 L and R, left and right modafinil. The right stereoisomer is supposed to last a little longer and maybe be more effective in treating ADHD, but it's, I've certainly clinically had some people who felt that armodafinil or Nuvigil worked much better for them, not just because it worked more over a longer period of time. I've also had some people who the armodafinil lasted too long and was more likely to interfere with sleep than with modafinil. How much is someone's belief in their own interpretations or perceptions? So one question I didn't answer, and I think you were the one asking about modafinil, how many days you stick with it. The other thing I should have thrown in at that time, and I usually do, is that not just individuals with ADHD, but everyone, there's some day-to-day fluctuation in how well your brain is working. And that's why a single day's treatment should not give us we shouldn't feel that it's given us a definitive answer one way or another on any substance. So some days, either we've gotten good sleep or there's been some favorable development and crazy politics in our world, or your husband, partner, dog, wife, kid, whatever, did something particularly sweet or nice for you? There's a lot of factors that can affect brain states. And we often over-attribute. I'm feeling great today, and that's the day I started the armodafinil, and that gives me a stronger impression than. So always we should try to wait a few days to form an assessment of how well something's working. So I think I've beaten that one to death. But if there's a different angle or aspect, or I haven't been clear, certainly go back to it. So hello, Diane. Just switch from immediate release generic Ritalin to immediate release generic Focalin. Used to take Ritalin every 4 hours, but it seems like Focalin's effect lasts longer, at least 5 hours. How much space do you advise? So again, we have general. We can do studies in the lab, but these studies in terms of how long a drug's acting are studies usually conducted in healthy volunteers or healthy individuals with the condition, and those are group averages. So there are individual variations in terms of how quickly drugs are absorbed, digested, metabolized, get to the receptors. So I'd say use what the package inserts say as a rule of thumb or a general guidance, but pay attention to what you yourself are doing. So I would certainly, if you're taking the IR every 4 hours, we would think Focalin is, if it's having a different effect with you, I would just try to consistently stick with a regimen for a few days of separating by 5 or, I would not jump by more than an hour or two at a time, and I would try several days in a row to see, am I consistently getting closer to what I want with this product? So James Alexander asks, are there any stimulant or quasi-stimulant medications weaker than Provigil, Nuvigil, and Sunosi, but stronger than coffee and Sudafed? So again, part of this issue of what's strong and what's weak is also a question of dosage. So I've had some people who were on, let's say 5 or 10 milligrams, this is depression, 5 or 10 milligrams of Lexapro, and then for whatever reason, this hasn't come up often, we're on Luvox, where or sertraline, the effective average dose in the US is above 100 milligrams, and they're saying, oh my God, why am I taking so much medication? And I remind them, a simple aspirin is just 325 milligrams, and you don't freak out about the milligrams there. So stronger, if you take enough caffeine, you will feel wired, agitated, jittery, and actually, so just because our social customs tend to encourage taking lower doses of that, or because it is a socially prescribed, not just medication considered entity. So whether something's truly weaker, whether we're just used to taking it at a lower dose, it's I guess at some level a semantic issue. I'd say that maybe the more important question is, what we consider a sympathomimetic, and that's one of the core. There are lots of definitions for what's a stimulant. Is a stimulant is primarily or sympathomimetic, is mimicking the sympathetic nervous system, and the core medication or core neurochemical there is norepinephrine. So the question is, let's look at, and for simplicity's sake, say Strattera is a norepinephrine reuptake inhibitor, and for simplicity's sake, bupropion is a norepinephrine and dopamine reuptake inhibitor. So is one stronger because it's working on two different agents or two different systems? Is it? I'm not answering the question, and I'm getting tongue-tied, so I think I'll just stop there. So I guess what I'm pointing out is that what we should probably, so CB is pointing out in sort of his response, perhaps Wellbutrin, is that it's important to think of, are we just flailing away at one system? Are we flailing away at two systems? And that may provide synergism or other benefits beyond just pushing really hard on one. But again, the dosage is a big issue. And then there's coffee or caffeine is not even directly that strongly working on dopamine. It's primarily working on adenosine, but then there are indirect profound effects on dopamine systems. And there, so I'll stop there. So, and thanks, Max, for providing the link to the generic drugs talk. That's the one where I'm addressing some of the inactive ingredients and the, what we know and what we don't know and what's allowed and what's not allowed. So James Alexander asks if I've heard of differences between generic Provigil, Nuvigil, and brand name. That one's a special case in that, at least in the US, so the only time I have ever seen drug reps acknowledging mortification at their own company's product or pricing strategies was with Provigil, Nuvigil. So Provigil, modafinil was available for decades. In the US, it was Cephalon. Is Cephalon? I think that's the company's name. Had exclusive rights to it. It was being used widely in France for years before that. And although clearly the research suggests it's helpful for keeping people awake and alert in a number of different situations, jet lag, sleep deprivation, physical conditions adding to lethargy, a variety of drugs adding to lethargy, things like ADHD, the company could have pursued a very broad set of indications and priced it cheaply and gone for volume but they went the other route and originally in the US got approval for sleep apnea, obstructive sleep apnea that isn't treated by CPAP, circadian rhythm sleep shift work disorder. There was a third, and narcolepsy. So all of those, at least in terms of diagnoses at the time, sleep apnea is actually fairly prevalent, and there's a lot of people disturbed by shift work where doctors or the individuals themselves aren't aware of the risks of changing your circadian cycle. So they went for tiny market and a high price. And then when their US patent was expiring, this is a long answer, sorry. The company developed or separated out the R stereoisomer and got a new indication. Anyway, it was always a pricey drug in the US at that time. 12%. Anyway, they almost doubled I'm forgetting the mechanisms of what they do. They essentially tried to force everyone who had been on Provigil into taking Nuvigil. So they doubled the price of the Provigil to about $25 a pill. This is in 20 years ago dollars, and priced Nuvigil about the price where Provigil had been. And even the drug reps were embarrassed at that because it was so blatantly trying to. So anyway, because it was so expensive, for years I had patients ordering it from overseas pharmacies and sometimes feeling that what they were getting being sold as modafinil was not genuine product. And I even had one patient whose brother was a pharmaceutical, he sent his a pill or two of each bottle to his brother who could run an assay to tell him whether it was really genuine modafinil. So at least in that era of 20 years ago, there were some outside the US manufactured and sold generic versions which did not seem to contain the proper amount of the active drug. I mean, theoretically, once the FDA in the US approved it for this country, anything that's being marketed as a generic should still have, within some amount of tolerance, the full amount. I have had patients who did feel that they could consistently tell the difference and got better effects from the brand name than from generics with both modafinil and armodafinil. Again, how often that is genuine physiologic difference and how often that's psychological expectation, I don't know. So DBoss asks if I see and is asking about specifically adult males, what dose they end up with on when they're taking Vyvanse along with Intuniv, and is there a typical target dose, and what do you see most patients taking long term? And again, so particularly in my talk on high-dose medications, my big thruster approach is I don't target dosages, I target responses. So I think our job should be looking at what is this drug doing in terms of, are we seeing benefit, and and trying to be as objective and quantitative about that as possible, because this gets really squishy in terms of, am I just really feeling better? Is it boosting my mood? And that's why I'm focusing better. That wouldn't be a bad thing, but then it would be good to know that this is primarily helping with mood or motivation rather than actual concentration or focus. So focusing on what we're getting benefit-wise and focusing on what is this dose doing to us side effect-wise. Are we feeling too jittery? Is it interrupting sleep? Are we having other side effects? Or is our blood pressure or heart rate going up too much? So that aside, and the other part of the question is, I've said here, I think guanfacine itself is a tremendous asset for many people. It's working through different pathways and over a different time scale than our stimulants. So it's a good combination for many. I don't use much Intuniv itself. I more often go with generic immediate release guanfacine at bedtime, seeing, at least again in my small sample size, there's research indicating both extended release and immediate release guanfacine are effective for ADHD. Again, it works slowly and indirectly, so there doesn't seem to be a need to get a steady state level, just a big enough signal, a long enough time. And but so trying to address your general ballpark question, I mean, I have some people on as little as 10 milligrams of Vyvanse. I've seen some people who did well on 210. Most of the people I work with are probably closer to 40 or 50. And certainly some of them seem to be able to lower the Vyvanse dosage a little bit with the addition of Intuniv. Others see added, or guanfacine, others see benefit added when they add the guanfacine, but don't change their Vyvanse dose. So Prince Hulk asks, am I related to Blake Kruse? And other than, I actually don't even know who Blake Kruse is. Maybe I'll look that one up. No, my first initial response is we're all related to each other. We're all human, and part of what we need to focus on in the world right now is being more human and remembering we're related, connected to each other. But I'm not aware of any direct, immediate family relationship. Kruse or Kruse is a fairly common German name, particularly North German, and there's different versions of it, Kruse being probably more widespread. And there is some, I mean, it's Kruse, it means cross in German, so there's probably some tie-in with Christianity, but other than that, I can't say much more about genealogy. So James Alexander asks, for the apparent relationship between father-son height differences in ADHD among Ashkenazi Jews. He mentioned during the Zoom question and answer, what do you believe are some plausible causal mechanisms? So for people who weren't plugged in before, one of the most extensively documented problems associated with children taking stimulants for a long period of time is some small decrement in height. And there are studies, actually one of the most clear benefits for taking prolonged, and prolonged means months off during the summer, off of methylphenidate, Ritalin, which is most widely studied, is that seems to help the bodies of some of these kids evade that. So there is less decrement in height among children who are taking longer holidays. But there's also been some studies haven't found this issue, and my concern was whether, rather than actually seeing a drug effect, we're confounding an ADHD effect with height. And part of it was based on, again, very small sample size, but 3 different individuals, none of whom had gotten childhood stimulants. All 3 males were of Ashkenazi Jewish heritage, and all of them were at least 6 inches shorter than their fathers, which is a moderately unusual discrepancy in height. And they weren't born during the Great Depression or periods of extreme dietary deprivation. I actually have since asked one other of my patients who is below average height and of Ashkenazi Jewish heritage, and his dad's exactly the same height. So it could be these 3 were outliers. A plausible causal mechanism is, again, the genetic contribution to ADHD seems to be polygenic. There are hundreds, if not thousands, of genes, each increasing the effect. And again, they increase the likelihood of developing a number of other mental health conditions, such as depression. Many of these drugs or gene effects seem to be common effects, and maybe some of these are very specific for only increasing the risk for ADHD. My thought is, again, that there could be some pleiotropy. I think that's the right word. I can't even spell it right now, but genes can have multiple effects on multiple systems. A drug that's winding up contributing to higher risk for ADHD, to me, it's not at all implausible, could affect regulation of other migration of cells, development of certain parts of the body, and result in shorter stature. So Prince Hulk asks, am I okay? Do I have Parkinson's? I'm shaking a lot. I think I do shake my legs back and forth. I think I did it much less when I ever worked with patients, when I did for 30 years, seeing patients directly. It seems more often when I'm sitting here long in a chair and presenting. I think it's probably more anxiety related, but brains and bodies do change as we age in terms of, I've always had small handwriting. Can't show you patient's name. So I keep records on tiny little cards like that. Small handwriting is one common sign in Parkinson's. Masked faces, so there's no facial expressions. I think I have facial expressions, but my Midwest monotone. Anyway, I don't think I have Parkinson's. I don't think other people have suggested I have ADHD or autism or 101 other things. Maybe we can spend a whole session on giving me your diagnosis of me. That I'll sort of end that one there. So Max asks, have I seen individuals who get good response from immediate release methylphenidate, Ritalin, but are unable to tolerate long-acting forms at any dosage or deliverance method? More often I have seen the opposite. There go the legs again as soon as I start answering. So more often I've seen people who felt they got a pretty good effect from the immediate release, but when they switched over to the long-acting form said, and this has been both with methylphenidate and with Adderall, this isn't an active drug. They gave me a dummy. This is a placebo. And part of it, again, is with stimulant medications. It's not just the dosage or how much is getting in. It's the rate, how quickly it's getting in, and or the rate of change of dopamine concentrations at the receptor level. So more often I see people who can appreciate or see the immediate effects, and the presumption is they're getting, again, not just the size of the hit, but it's more quickly changing dopamine at the receptor level. And with these slower acting forms, the ramp up is so gradual, they're missing that, and whether or not they're getting some benefits and just missing the feeling of it, so that feeds back and says to them they're not getting anything. So I have had some. I mean, usually if the situation Max reports that the immediate release works and the long acting they can't tolerate, usually it's they can't tolerate it because it just is lasting too long in their bodies and keeping them awake too late at night and disrupting circadian rhythms. So yes, I've seen that. So Mr. AKA asks, do I have any patients on a compounded dosage of a stimulant? So I'm thinking right now, not actively. And how often? I'd say it's been rare in the past. I mean, one is there has been an increase in compounding pharmacies. More often, I've seen it with certain different antidepressants. I've seen it with people who felt they were with pain medication, with opioids. Most often, I've seen patients get compounding dosages. I've certainly seen it with Ozempic-like drugs, where it's just there was a question of supply and demand and what could be obtained. I am leery. I think at some level, compounding pharmacy is wonderful because, again, I think there probably are some people who are genuinely, their body's extremely sensitive and has adverse responses to some of the additives that are maybe commonly commercially available. I think that number is probably a small number of people. I'm leery because even though you would think, or you could interpret at some level, I'm more safe or secure with this local pharmacist who is, I trust him rather than trusting this big mega corporation who's churning out billions of pills a day. But very clearly, the data overall would suggest that big pharma's drugs are safe. I mean, the quality control, the cleanliness standards. I mean, there have been a number of cases or series of cases because it's usually they make lots of people sick. This doesn't mean all compounding pharmacists are, not hygienic and not safe in what they're doing, but there have been enough problems in the field that personally I would be much more worried consuming a compounded drug than taking an off-the-shelf drug from a big pharma company. That's my bias. And again, I think the evidence is there that in both situations, the percentage of problems is uncommon, but higher with compounded products. D-Bosk asks, how much does having low iron affect ADHD symptoms? It's not a topic I've researched strongly, other than getting back to the legs moving. Clearly with restless leg syndrome, there's a fairly substantial body of evidence showing low iron can trigger that. I know there is some work on iron and ADHD, and your comments have just made me put it down to look that if there is enough information to research to speak intelligently on, it'll be on my list in the future. But I don't, off the top of my head, I'm not aware. I just don't know what's been studied specifically with ADHD. So Jonathan Anderson is in his second week of taking a milligram of guanfacine. he feels he's going to need to go up to 2 and then add some type of stimulant. Will the guanfacine cancel out the anxiety that I got from the stimulants before? So again, individual results vary, and I can't give specific recommendations. What I would say is the benefits you're seeing or not seeing 2 weeks on 1 milligram of guanfacine don't tell us much at all of how profound they will work. That most people are seeing very little in the first 2 weeks of guanfacine and much more robustly in the 2 to 6 week period. So it may well be that you need more, but I would, in general, would recommend someone who's seeing absolutely nothing on 1 milligram at 2 weeks. My general recommendation would be keep taking it at that dose for several weeks more before we're sure. So I don't know how much rigorous research there's on this, but very widely, clinically, a major use of guanfacine is exactly the situation you described. It's someone who could not tolerate a stimulant. Maybe they could clearly see they got some benefit for ADHD, but just felt too revved up, even at the lowest doses, too anxious, too worried, and stopping the stimulant, putting them on guanfacine, stabilizing the system with guanfacine, and then going to the stimulant, it's extremely likely that individual will be able to tolerate the stimulant at that point in time. So yes, it tends to be very effective at canceling out the anxiety while preserving or actually enhancing ADHD benefits. So Max asks, how beholden are psychiatrists to governmental policies? If a directive is passed by the Health and Human Services to stop treating ADHD with stimulants, would you have to follow that? So one is so as it is now, when the FDA approves a drug, it says this is the indication for it, this is the recommended dosage, and those are recommendations. And very explicitly in US law, a doctor is allowed to use any approved substance for any indication that he feels there is scientific evidence evidence that it's more likely to be useful than harmful. And that evidence actually could be, I know 3 people who were treated by this by another doctor. So you don't have to cite rigorous studies. Now, on the other hand, so that's the general framework in the US. On the other hand, if you are, and the FDA very seldom is the body going after individual doctors. It's far more often each state has a medical board, which is supposed to police or regulate doctors in that state's jurisdiction. And the most common way of blocking or preventing a doctor from doing something is to take away that doctor's license, which is, again, a process through the state medical boards. And certainly if someone is practicing using drugs in a certain way that is not community standard, so they're using really high doses of opioids for pain or stimulants, and a patient treated on that regimen winds up having dies or has some significant injury or causes some social problem, that's the most common way those problematic prescribing patterns are detected and arise. But in this day and age, unlike 20 years ago, now each state in the US is required actually to have a database every time a controlled prescription is prescribed. And each state is a little different. There are worrisome patterns that get flagged. So just dosage range, if you prescribe even one patient on the dosage range, that raises a flag. If you have multiple, that raises another flag. Or if you are combining medicines that may be dangerous together. Again, it could be completely beneficial to the patient and rational in terms of research, but many doctors are leery of getting flagged at all because they don't want to be the investigation itself, even if your license doesn't get taken away, can be expensive. It can be anxiety provoking. It can be undermining. It's not an outcome most people want to directly deal with. So, again, the current government in the US doesn't care much about historical patterns or policies. So they've been happy and eager to throw out precedent in all sorts of ways, and they could certainly, wouldn't it all be surprising if they simply said X, Y, or Z is inappropriate? I mean, the FBI has actually currently issued a directive to the public that any doctor anywhere, regardless of how their state regulates it, is prescribing gender modifying gender hormonal therapy that helps modify secondary sexual characteristics. They're asking in children, which again is completely legal in many states. It's been banned in some states. Many of those bans are under review, and the Supreme Court is going to be hearing a case like that this term. Anyway, the FBI is already soliciting the public to report any practitioner who they even suspect is using these medications with children. That is, I would argue, a very creepy, intrusive, authoritarian, inappropriate role of the government. Again, I think the medical world, not that they've been perfect, they absolutely don't have a perfect track record, but know more about regulating medicines, medical treatments, both procedures and drugs, than do letting the general public vote on it or letting judges or legislators decide on that. Anyway, I'm getting into the politics, but we are embedded in a world where there are politics. So I'm not sure if I even answered Max's question. So if Health and Human Services passed a directive to stop treating ADHD with stimulants, I mean, what I think they would do, I think, I mean, if they did it and then they said any doctor that defied it, they would throw in jail and take away their license, that would discourage most people, probably me. But I think more effectively, they would they would do it through regulating the pharmacies. They would just either ban the substance from any legal use at all, or, I mean, it's hard for me to see that they would. So with most of the stimulants in our country right now, the FDA approved use is for ADHD. Are they used for depression? Yes. Are they used for people with head trauma and other conditions who have excessive lethargy? Yes. Are they still used even for appetite suppression in some situations? Yes. But I think it would be easier just to ban the substance than to say, oh, okay, we're allowing people to use it for all these off-label uses, but we're forbidding what was previously the on-label use. I mean, I think they would be cutting off, if this was their goal, they would be cutting it off more globally rather than the level of prescribing. So, but that's all speculation. So DBoss asks, how long do I find that Vyvanse lasts? Do you ever prescribe immediate release boosters for the afternoon? So this individual takes it in the morning, then falls asleep around 5, 6. Do you have any advice? Thanks. So my experience is for most people, Vyvanse lasts around the 12 to 14 hours that the formal studies suggest. Vyvanse, and I talk about this and I should be wrapping things up quickly. So Vyvanse is one stimulant. It's about the only one that you can prolong the effective life, and I won't say half-life, effective life by increasing the dose. So I talk about more of that, why that is. But yes, even though the once-a-day or long-acting stimulants were mostly designed to allow once-a-day dosing, it's fairly common to augment them at certain times a day by immediate release. And I'd say maybe a little more often is early afternoon or siesta time. But if later in the day is where, again, I would say if it works for you and it's consistently working, great. And that's more important than whether that works for lots of other people. So DBoss also asks, what about Disoxin for ADHD? So most people, including most doctors, including some who say they're working with ADHD are unaware that in the US, disoxin, which is methamphetamine, so it's speed rather than amphetamine, is FDA sanctioned for treating ADHD. I have only had a handful of people that I felt comfortable prescribing it for. And I do have a talk on comparing methamphetamine to amphetamine. I do think the risk for addiction is higher. I do think the risk for psychosis is higher. Most people don't have those, but those are really, really bad side effects or outcomes to produce in an individual, given that they have long-term life implications rather than even if you try to immediately treat psychosis or addiction. So I try to use as little as possible is how I'd answer that. And I would not encourage too many people to seek it out. Mr. AKA is compounded naltrexone, reduced chronic leg pain by 80% with no perceivable side effects. And Mr. AK has had good experience with compounding pharmacies. Again, I think in general, the outcomes are good. But I worry more about, you're relying on the competency of one individual or a tiny handful rather than the competency of a larger system, and they both can break down in different ways. There. So James Alexander is, why would atomoxetine be even less tolerable compared to stimulants? And again, this is simplistic, but if all the stimulants we have are working on both dopamine and norepinephrine, and that may be a more sane way to mess with a complex system than banging away single-handedly on norepinephrine. And again, there are other effects at a lower level and a slower rate from atomoxetine, but it may be that it's just too single-handedly perturbing systems. That's not a precise explanation, but I'm trying to wrap up work. So Luke was prescribed Prozac fluoxetine after 20 minutes with the physician who is essentially trying to treat depression when they think it's ADHD. I'd say there are many systems, many doctors are trained and much more familiar with depression. Many of them are skeptical and leery and don't consider ADHD a real condition. I say that's unfortunate. Hopefully we'll keep educating them. If you are not, so again, I can't make specific recommendations, but in the general situation. So the question is, if you feel inside that the fluoxetine is not going to work because depression isn't the primary problem, do you abandon ship and pay out of pocket for a private doctor, or do you keep trying to work within the system? Again, there's some parts of that. This has to do with your own finances. So the things I would say is urgency. If it feels really important really quickly to get treatment for the ADHD, then it might make sense to switch and not spend time here. Usually ADHD is a lifetime chronic condition, and unless circumstances are saying you need to deal with it immediately, I would say you probably are increasing the doctor's trust and belief in you if you give it a good shot and try the fluoxetine for 6 weeks. And if at that time you're not seeing anything, and again can reinforce what seem to be ADHD and not depression symptoms, then you're on better ground with that doctor for trying something that may be more helpful. But that's general advice, and I don't know how well it will work in that condition. So do Doctors operate too much by the book. I had a psychiatrist who's unwilling to try off-label meds or listen to my personal research findings regarding. So, I mean, one is I only get to work with several hundred, maybe a little more than 1,000 patients in my lifetime directly. Part of it is I have people I've worked with for more than 25 years. My approach has always been to do good work with small rather than churning through greater numbers. But my interactions with other psychiatrists are also small n. But in terms of the reports people give, yes, I think there's a lot of psychiatrists who are overly cautious and think what the FDA said. And again, not even being aware. Many doctors aren't even aware that when the FDA makes recommendations, it explicitly says, we know there will be some people who need to respond to lower doses or higher doses. Lots of people are locked into, and some aspect of it is cover your ass, and pardon the phrase, medicine. They're so afraid of lawsuits, and which can be devastating and expensive and horrible. Not having personally had to deal with it, but yes, I can tell that they are. Many are just unwilling to stick out from the herd in that way. And many also, so when I went through MD and PhD training, this is an oversimplification, but I think it's a really useful one. People would ask, why are you doing both? And I would say there are two very different ways of thinking, and this is getting at just one angle of it. PhD wants to be the first person to do something. A doctor wants to be the second person to do something. So not that there aren't maverick doctors who are doing innovative new things, but doctors, partly because if you do an experiment and it fails, it's the experiment that failed. If that experiment is with human beings, you may have caused considerable harm. So doctors want to do things that are safe and not causing harm, and that makes many of them cautious. And again, I'd say overly cautious. And also, many doctors don't feel like that they have the time to be exploring the research and knowing what actually we know that may be separate from FDA or other recommendations. So socially dyslexic gaming asks, are there any ADHD meds that could also be helpful with severe agoraphobia? And no topic is too off topic, even politics, as people here know. So one is with severe agoraphobia, probably behavioral cognitive approaches are likely to be as helpful. Most of the research, my understanding, and I'm not completely fresh on this right now, are serotonin reuptake inhibitors, and other medications help process anxiety. This pure serotonin drugs aren't that helpful for most people with ADHD, but they can be very helpful with ADHD in combination with anxiety, or anxiety in combination with ADHD. Or this may be a situation to look at something like an SNRI, like duloxetine, which could help with both ADHD symptoms and with anxiety connected with agoraphobia. So again, I'm trying to race through the last ones. Frank, should I quit my job if I cannot handle it, or wait until I get terminated? ADHD. The other jobs pay much less. There's a lot embedded in here, so this is not specific advice for you. If you're in the US, ADHD is an officially recognized disability. And my approach is usually, once you have that out in the open and directly address it, the employer is very, they can fire you if you are not able to do your job, but they cannot fire you if it's the failure to provide accommodations for your ADHD that is preventing you from doing the job. So I do have a talk on accommodations. I tend to call them efficiencies rather than accommodations. And I can get that there's still lots of stigma and reluctance, but you are often in a much better legal position if you are actually direct. And even if you didn't earlier say it, but to say, this is part of what I'm dealing with. This is what you can do to help me make a more efficient, effective worker. And the other thing I would say, and this may be really hard depending where you're at, to fire you to train a brand new person. I mean, at some level, your employer wants you to succeed. That's why they hired you. That's what they're trying to get out of you. And if you can get back to a framework where the manager or supervisors or others, or you are trying to work together to improve things better for your work and the team's work and the company's work, then you're working together. If you're working against them, then it's going to be a lot harder. And particularly California also has additional strong state regulations on top of that are more protective than the federal ones. So the two together, you are in a good state to be confronting this. So Dropneck asks, is Vyvanse safer than Concerta in practice on your experience? So of the long-acting forms, Vyvanse is I have good results with some others. It's my favorite amphetamine-based product. Concerta is my favorite methylphenidate-based product. I think in general, both are safe and effective. I do think that there are risks to amphetamine in terms of both addiction and psychosis that are greater than they are there for methylphenidate products, and that includes long-acting ones. So just in terms of safety, but Concerta is probably safer, but Vyvanse is probably more effective, and the risks of bad things are small with each. So thanks, Max, for providing the link to meth and Adderall, comparing the two. And Max also provided a link to accommodations for schools. So Dropneck, this is the last one I'm going to try to address. In Greece, list dexamphetamine, so Vyvanse or Advance, I'm forgetting the British name, is approved this year, and probably it will be available in drugstores. Yeah, so I do have talks on Vyvanse. It's one of my more popular ones. I would check that one out, and I'm happy to answer other specific questions about it you have before considering it or discussing who it might be appropriate for or not. So Frank asks if there's any non-addictive sleep medications. So I think I have a talk on orexin, dual orexin antagonist blockers, DORA drugs, and also on Medium I've written about it. That is where I would start in terms of non-addictive sleep meds. So thank you. Stay healthy, stay happy. It's great to hear all your questions, and I will be back next week and hopefully cough-free and well-rested.